I'm Kathleen Carter, RN, RVT. I'm a vascular sonographer. I live and work in Norfolk, Virginia, affiliated with Eastern Virginia Medical School. And I'm going to talk to you today about abdominal ultrasound, specifically the aorta and mesenteric systems. I'm going to talk about the abdominal Doppler, protocols and tips, specifically about the abdominal aorta and the mesenteric system. A little review of anatomy. The celiac trunk comes off just below the diaphragm, giving rise to the hepatic and splenic. And usually within 1 to 2 centimeters below that is the takeoff of the superior mesenteric artery, followed within another centimeter or so by the renal arteries. The inferior mesenteric artery is usually located just above the iliac bifurcation prior to the division of the iliacs, and the common iliacs then of course divide into the external and internal iliac arteries. We're going to talk about aneurysmal disease that affects the abdominal aorta, aortic iliac occlusive disease, a little bit about dissection, and then we'll go on and talk about the mesenteric vessels. The adult abdominal aorta normally tapers as it traverses distally. It is normally about 2 centimeters in diameter. When ectasia is present, the diameter may range between 2 and 3 centimeters. So let's look at what this looks like. A normal aorta has smooth walls. You can see the takeoff there of the superior mesenteric artery and the abdominal aorta tapering as it traverses distally. When ectatic aorta is present, then you see you have irregular walls, some dilation that is less than an aneurysmal dilation, but irregular borders to the wall of the aorta. Once dilations become greater than 3 centimeters, and some literature says greater than 3.5 centimeters, that's usually considered aneurysmal disease. Once that now becomes greater than about 5.5 centimeters, intervention is usually indicated. In the iliac arteries, we usually look at an increase in the diameter of the artery by 1.5 times the normal diameter to call that aneurysmal. When the iliac arteries exceed 3 centimeters, that's when intervention is usually indicated in the iliac arteries. It's very important to measure these accurately, particularly since we're going to be measuring and following patients serially for increase in size of any aneurysm. So you need to be perpendicular to the vessel in both the transverse and longitudinal views. And we're going to look in transverse sagittal and perhaps coronal planes. So this is a transverse view of fusiform aortic aneurysm. We'll look and evaluate that, measure carefully, and estimate the amount of thrombus that might be present within the lumen. The iliac arteries generally are about 15 millimeters in size in men and a little smaller in women, and the externals are a little bit smaller than the common iliacs. When an iliac aneurysm is encountered, and this is a very large iliac aneurysm, almost 4 centimeters, we need to measure that. Again, estimate the amount of thrombus within that. You can see there's a smaller lumen, residual lumen, in this very large iliac aneurysm, and it's then evaluated both in transverse and longitudinal views. And you can see that this one actually extends down into the bifurcation of the iliac, internal iliac and external iliac arteries. When we encounter these, we need to measure them again carefully with a perpendicular orthogonal plane so that we're sure that we're measuring accurately. Aneurysms are usually fusiform. They may be saccular. It is good for us that most of them are fusiform because those are easier to measure accurately. A true aneurysm involves all 3 layers of the arterial wall. Pseudoaneurysms or false aneurysms are usually caused by injury or a hole in the arterial wall with flow maintained into a hematoma and do not involve all 3 layers of the arterial wall. Here's an example, both in longitudinal and transverse view, of fusiform aneurysms. You want to make sure, again, that you're truly perpendicular as you're doing these measurements. Saccular aneurysms produce a little bit more of a challenge to figure out exactly where to measure. It's usually an outpouching, as seen here, and may be easier seen in the long axis. So we're going to measure in both the longitudinal and transverse views for accurate measurement, and they should be somewhat similar. Now, I talked about how important it is to do accurate measurements, and we know that maximum aneurysm diameter measured by ultrasound and standard axial CT is not equal. And that's due to aortic angulation. Many times as people get older, the aortic neck will angulate, particularly when people begin to get a little bit shorter. It almost becomes redundant. So a study was done at the institution where I was working in Norfolk, Eastern Virginia Medical School, and that study was published in the European Journal of Vascular Surgery. I'll give you that in a moment. But the important thing is that we compared the ultrasound measurements to 3D reconstruction CT scans in which a perpendicular line could be mechanically dropped in and measured, and then compared that to axial CT. And in the presence of aortic angulation, there was significant difference in the measurements, and that's because the axial CT is doing a transverse cut through to the body, and when the aorta is angulated, you end up with an oval measurement, which is slightly larger on axial CT. The orthogonal CT or 3D reconstruction CTs in which a true perpendicular line was placed correct for that angulation, as does ultrasound. And as sonographers, we can correct for that angulation and perform these measurements perpendicular to blood flow. And again, this was published in the European Journal of Vascular and Endovascular Surgery in 2004 with the main author of Richard Sprouse. Good orthogonal measurements look like this. You make that fusiform aneurysm as round and large, as you can, and they should be fairly symmetrical, and that's what a good measurement should look like. Let's talk about the abdominal aorta spectral Doppler. When we encounter the aorta proximal to the level of the renal arteries, SMA and celiac, in that region, you're going to have more diastolic flow because the aorta is feeding partially the celiac artery, the renal arteries, which they're feeding a lower resistance vascular bed, such as the kidneys, the liver, and the spleen. So you're going to get more diastolic flow. Once you are below the level of the renal arteries, the aorta is pretty much just feeding a high resistant peripheral vascular bed and has a much higher resistant flow pattern. Aortoiliac duplex can localize disease. We're going to be doing direct assessment of the aorta and iliac vessels. And careful color duplex ultrasound can determine a number of things for us. We can decide if the disease is focal, figure out the length of any focal disease, or is it diffuse throughout the entire arterial tree. And this piece of information may impact whether or not the patient gets surgical treatment, endovascular treatment, or just medical therapy. So we can determine the exact location of disease, estimate the severity, determine the length of stenosis. We may even be asked to measure the external diameter of the vessels and the residual lumen, and that may assist in sizing of any appropriate endovascular devices, such as catheters and balloons. We need to use high-resolution duplex ultrasound that has good spectral and color Doppler. We're going to use a variety of transducers that are based on the patient's body habitus. Usually we keep these patients in PO for 8 or 12 hours. They usually do not need a bowel prep. So the crux of the protocol is going to include examination of the aortoiliac segments in transverse and sagittal planes, the entire abdominal aorta, and the iliacs. And the iliacs are usually best imaged in the long axis. And I include a picture here of a 3D reconstruction CT just so that you can see how tortuous these iliac arteries can be in many of these patients. And it is very difficult to maintain a 60-degree angle around a lot of the bends that you're going to encounter. So it becomes a bit of a challenge. Color flow can really be helpful in these exams. Because the iliacs are tortuous, they're deep. You may have overlying bowel gas. So you may need to use different approaches, and the lateral decubitus approach can be very helpful sometimes to change the approach and lay the vessels out in a more opportune approach for achieving that under 60-degree angle for spectral Doppler waveform collection. Need to recognize that there are some limitations and challenges to this exam, which would include patients who are obese, poor patient cooperation, and the ever-present abdominal bowel gas. We're going to look at the aortoiliac, or the aorta first in proximal, mid, and distal and collect samples there. And then the iliac, we'll look at the common iliac, the external iliac, the hypogastric or internal iliac in both transverse and longitudinal views using imaging, color flow, and Doppler. Special attention can be paid when there are changes. If you have your scale and your PRF set correctly, the color flow can give you a clue to where there are areas of increased velocity that you might need to investigate. Sample at less than 60 degrees with your spectral Doppler being parallel to the vessel wall at proximal, mid, and distal in each segment of the artery as you go all the way down to the groin. When we evaluate the abdominal aorta here, you can see this is the proximal aorta sample being taken parallel to the wall, and you would do proximal, mid, and distal. If there are any increases in size in the aorta as you go down, obviously we're going to measure those. We want to be, as in this example of the external iliac artery, parallel to flow at an opportune Doppler angle to get the optimum waveform. When you do encounter a stenosis, as seen here in a common iliac artery, we want to sample prior to the stenosis, within the stenosis, and document the peak systolic velocity, and then also document the post-stenotic turbulence that's present. In order to call a 50% diameter reduction that you might encounter across the course of an iliac artery, you need to have at least 100% increase in the peak systolic velocity from the adjacent segment and document the post-stenotic turbulence. There are some other criteria in the literature for if you want to break down anything between 50 and 99% stenosis, and sometimes a ratio greater than 4.1 is used to suggest a greater than 75% diameter reduction, or a peak systolic velocity greater than 400 centimeters per second. The severity of lesions distal to a high-grade stenosis may be underestimated, so that may be a limitation of the exam as you go through. So if you have a high-grade stenosis and then encounter further stenoses downstream, those stenoses may be underestimated in their severity because the head of pressure isn't going to be enough. Another sort of hampering of this exam is that in the aortoiliac segments, you can have a very severe stenosis in the iliac, or even a short segment occlusion, and if it's really well compensated with collaterals, at rest the ABI may be normal and the common femoral artery be near normal, and the only way you'd really uncover that is with exercise or reactive hyperemia. So that may be a limitation of looking at this exam. This is an example of when it is clear that there is not good compensatory flow. This is a common femoral distal to severe iliac disease. You can see that there's a very delayed rise to peak. There's a lot of diastolic flow when you normally would see no diastolic flow, and a dampened waveform where the peak systolic velocity is only in the 30s. Occasionally we will identify aortic occlusion. When that is done, you want to see where the runoff is, where the collaterals are coming out, document the occlusion with spectral Doppler, and follow down. Here you can see this is occluded all the way to the terminal aorta and no flow present within that segment by spectral Doppler. When we talk about dissections, sometimes you can identify new dissections or even old, more healed dissections. You can see the intima here in both transverse and longitudinal views is lifted away from the wall. You may or may not get 2 channels of flow within this. It just depends on whether or not the dissection has begun to heal down or not. But this should be documented in its length, and if there are 2 channels of flow, certainly should be documented with spectral Doppler in both areas. The extent of the aortic dissection should be determined. These can spiral up and dissect into the visceral vessels as well. Here's other examples of where plaque was present, and there is a short segment dissection that is curling up in certain portions of the cardiac cycle and then laying down in certain portions of the cardiac cycle. And in transverse here, you can clearly see where the aortic dissection is. You want to have your PRF or your scale set so that if you do have any cavitations into the wall of the aorta, as in this case where you have a short dissection that became aneurysmal, if there's a small amount of flow going into this cavitation, then you want to be able to pick that up, and so make sure that the color scale is set appropriately. You can have pseudoaneurysms, and in this case a multilobular pseudoaneurysm associated with the aorta. Does not involve the layers of the wall of the aorta, as you can see, and that should be measured. Color Doppler and spectral Doppler can identify where there's any flow within those pseudoaneurysms. Also should be measured in size and what the residual lumen is that is still patent. We're going to go on now and talk about the mesenteric arteries that come off of the aorta. We're going to talk about the celiac, we're going to talk about the superior mesenteric as well as the inferior mesenteric arteries. Again, the review of the anatomy. The celiac trunk is the first branch off of the aorta after the diaphragm, followed within 1 to 2 centimeters by the superior mesenteric artery, and then the inferior mesenteric artery is located just above the common iliac bifurcation. The celiac axis is the first abdominal branch off of the aorta. It is about 2 to 3 centimeters in length and gives rise to the splenic, common hepatic, and left gastric branches. This can be evaluated in either longitudinal or transverse views. You get that sort of Y division there where the hepatic and splenic form a seagull or Y approach, some people call it. This again can be evaluated in either longitudinal or transverse, whatever works out best to see the bifurcation of those. Replaced hepatic artery can occur when the hepatic artery arises from the SMA instead of the celiac, and that can happen about 40% of the time. It is very rare for there to be a common trunk of the SMA and the celiac. So replaced right hepatic can occur about 17% of the time, a common celiac and SMA trunk about 1% of the time, and a separate hepatic off of the aorta about 1% of the time. And here is the celiac artery seen in transverse, so you see the aorta in transverse giving rise to that 2 to 3 centimeter length of celiac artery, and then the origins of the hepatic and splenic artery. We normally think about atherosclerotic disease when we're talking about the mesenteric vessels, but this is just an incidence in which we encountered high velocity, turbulent flow within the celiac axis as it took off from the aorta. And in this particular case, it was not due to stenosis, it was due to a dissection. So just keep in mind that there are other things besides atherosclerotic plaque that can cause increased velocity in these vessels. There was a study at Dartmouth that also suggested that we want to note the flow direction in the hepatic artery, and when the flow direction is reversed, that is usually compatible with severe stenosis or occlusion in the celiac artery, and you can backtrack to identify that. The superior mesenteric artery originates a centimeter or 2 distal to the origin of the celiac artery. It most often takes off from the aorta at a very sharp angle, almost 0 degrees, comes up, and then courses inferiorly parallel to the aorta as it arborizes into many branches. Color Doppler can be very helpful to identify the distal course of this and its branches. The normal spectral waveform in the fasting patient is fairly high resistant, and then postprandially, when all the blood vessels in the mesentery will dilate, you get forward diastolic flow throughout diastole. The inferior mesenteric artery looks much like that of the spectral waveform looks much like that of the superior mesenteric artery. It is the last major branch off of the abdominal aorta before the iliac bifurcation. It originates from the anterior aortic wall and then curves to the left and inferiorly. And it serves as a source of collateral flow. Some people have a difficult time identifying the IMA, and inability to identify it doesn't mean that it's occluded, it just means that you were not able to identify it. But with practice, it's not that difficult to identify. Now, these blood vessels are connected through a rich collateral network. through the arc of Rayland, sometimes called the wandering artery of Drummond. And this is very helpful because one vessel remaining of the three can supply the entire small bowel. So it's very important to know that these have such a rich collateral network that's present. Normal Doppler spectral waveform analysis of the celiac demonstrates forward flow throughout diastole with spectral broadening expected due to the size of the sample volume relative to the size of the artery. We expect peak systolic velocities normally to be less than 200 centimeters per second. In the superior mesenteric artery, we expect high resistant flow in the fasting state with a sharp systolic upstroke. There may be a little bit of turbulence proximally becoming more laminar distally as it does that sharp turn off of the aorta. We expect that normally peak systolic velocities will be less than 275 centimeters per second and the end diastolic less than 45 centimeters per second. So the mesenteric vascular diseases that are usually present, we're not going to talk much about acute mesenteric ischemia because there's very little role for the vascular laboratory or Doppler in the diagnosis of this disease. We'll talk more about chronic mesenteric ischemia. We may see ischemic colon disease, celiac axis syndrome, or mesenteric venous occlusion. Acute mesenteric ischemia is relatively rare. It has a very high mortality. It requires a very rapid, aggressive diagnostic and therapeutic approach before the bowel begins to die. Problems associated with this disease include delayed or uncertain diagnosis that leads to death of the tissue, accurate identification of where the lesions are, and usually intra-op is where decision-making happens. The etiology of acute mesenteric ischemia is usually embolic or thrombotic. It can be caused by venous thrombosis. Duplex has no real proven role in this. It's not a reliable test in unprepped patients with acute symptoms, and usually these people are diagnosed with biplane angiography. The clinical features associated with acute mesenteric ischemia is severe abdominal pain out of proportion. They're usually elderly with a history, comorbid cardiac and peripheral vascular diseases. They may have peritoneal signs and symptoms and bloody diarrhea. Atherosclerosis is about the main cause of chronic mesenteric ischemia. About 95% of chronic mesenteric ischemia is caused by atherosclerosis, and it usually involves the orificial portions, first 1 to 2 centimeters of the major visceral vessels. When we talk about the other 5% of things that can cause mesenteric ischemia, it can be arteritis, radiation, the autoimmune disorders, fibromuscular intimal hyperplasia, arcuate ligament compression, or coarctation of the abdominal aorta. 2 of the 3 mesenteric vessels, celiac, SMA, and IMA, must be abnormal for that patient to be symptomatic. If one is abnormal, you have to really try hard to find that IMA and look for any disease, especially if the patient is symptomatic. A single patent visceral artery is capable of supplying the entire small bowel. So if that occlusive disease develops slowly, patients can be asymptomatic with only one vessel really supplying it. Remember, though, that if one vessel is diseased, there may be elevated velocities throughout the remainder of the vessels due to compensation. So that piece of documenting peak systolic turbulence or post-stenotic turbulence to rule out compensatory flow as the main cause for increased velocity is very important. All 3 vessels are usually involved when there is disease present. One of the 3 vessels may occlude, and that's usually the celiac axis if it does. The SMA is usually the one that is most involved in narrowing, significant narrowing. Signs and symptoms of chronic mesenteric ischemia can include a gnawing and dull periumbilical or epigastric pain. It usually is occurring postprandially after meals and may persist for 1 to 4 hours. These patients develop a food aversion because food is what is causing their pain. They don't want to eat. They have significant weight loss and may get cramps in the abdomen that radiates to their back. Many times they have an epigastric bruit. The diagnosis can be made for this disease with either duplex ultrasound or angiography. The typical patient presentation is a female in 40 to 70 years old, displaying postprandial pain, weight loss, food fear, and usually these patients take a long time to get worked up for diagnosis. They're usually worked up for many months for ulcer, gallbladder problems, cancer, before the diagnosis is made of chronic mesenteric ischemia. So here are some examples of celiac and mesenteric stenosis where you can see that the velocity is so high, over 700 centimeters per second in the celiac here, that in its aliasing you can see a bruit associated with it, particularly in the SMA where the velocity is almost certainly over 500 centimeters per second. And then in the hepatic, distal to that celiac, you can see that the waveform is abnormal, it is bowed over, there's a delayed rise to peak, and it's certainly post-stenotic. Here is the splenic in that same patient, where you see the splenic artery again is bowed over, has a delayed systolic rise time, and has a transmitted bruit even still within that splenic artery. This example is a very high celiac artery flow, but this was not due to celiac artery stenosis. This was a patient who had an infrarenal aortic occlusion and critical SMA disease. So the main runoff from the aorta was going out the celiac, causing a very high amount of flow within that. Stents. So many times these patients are treated with stents, and when we're looking at patients after the stent is placed, we need to walk the Doppler throughout the course of the stent. You may get higher velocities throughout the course of the stent as long as there's no focal increase. That may just be due to the decreased compliance of the vessel because of the stiff stent that's placed in there. But we would expect in a certain percentage of the time that these stents may restenose. So we want to walk the Doppler all the way through them, from the aorta all the way through to the end of the course of the stent. Interpretation of mesenteric disease: the celiac velocity should be less than 200 centimeters per second. If it's over 200, and has poststenotic turbulence, that's consistent with significant celiac disease. The SMA velocity should be less than 275 centimeters per second. Again, greater than that may be consistent with significant stenosis within that vessel. And the IMA, there's no absolute number associated with that, but it should be visualized with normal flow patterns and any focal increase in velocity documented. Are the distal waveforms dampened? Is there poststenotic turbulence? Is there a lot of collateral vessel development? All of those that can be clues to hemodynamically significant stenosis present. Now let's talk briefly about median arcuate ligament compression syndrome. Celiac artery velocities can be increased due to extrinsic compression by the median arcuate ligament. In that instance, the signals will normalize and decrease in velocity when the patient is examined sitting erect or during a very deep breath. So the SMA is almost never involved with this syndrome, and patients usually have a normal arterial wall and aorta. So we want to evaluate these patients both in the supine and sitting position, and if you can normalize the waveform and velocity, then it's not due to intraluminal problems, it's due to extra luminal compression by this median arcuate ligament. Now, interestingly, most patients who have this are not symptomatic. And about 50% of patients that have this situation are completely asymptomatic, which kind of indicates that the symptom complex may not be due to arterial stenosis. Thank you very much.